healthcare in which these technologies emerge. I want to shift the moral lens from the physician-patient relationship to the social or public health arena, to look at questions of social justice that are posed by genetic advances in light of the potential for an ever-growing genomic divide between what Silver calls the gen-rich in this country, those who will have access to genetic breakthroughs, and the gen-naturals, those who will live with the natural lottery, between the genetically rich and the genetically poor countries of the world. I want to ask, how will advances in genomics improve health in developing countries? What do personalized medicine and gene therapy mean to 1/3 of the world's population who live on less than $2 a day? How are genetic investments likely to impact healthcare for the 45+ million people in this country who are currently uninsured or underinsured? In other words, how will we decide who will reap the benefits of the genetic revolution and who will bear the burdens? Whose Holy Grail? In what follows, I want to place the question of genomic justice in the context of Roman Catholic social thought, the more than 100-year reflection on what it means to build a just world, to seek a common good. To do that, to situate our discussion within Catholic social thought or any other body of religious literature, does not solve the problems for us. It does not dissolve the complexity or dissipate the ambiguity. What it does is it gives us a place to stand. It gives us a perspective from which to view and to assess genomic advances and their applications. And it provides us with a horizon of values. More important, as I hope to show, our fundamental convictions lend a distinctive, and I want to argue, a necessary voice to the debate that will shape our genetic future. A few years ago at Notre Dame, I was teaching an undergraduate course in medical ethics, and among my students was a young woman from Uganda. On one particular day, we were engaged, I teach a class of about 50 in a sort of amphitheater-style room, and we were debating, hotly debating, a case involving a question of termination of treatment. It was a teenager. It was one of those cases that ethicists love because it was a teenager who was right on the cusp of his 18th birthday, and he had end-stage cystic fibrosis. And the question was, you know, if he was a few days older, he could decide for himself, but he wasn't. Anyway, the question was, who should decide whether he should continue treatment or not, whether he should have aggressive resuscitation. His mother wanted him to have the treatment. He didn't want him to have the treatment. His girlfriend was stuck in the middle. And I looked over at one point in the discussion, and there was my student from Uganda, and she was just kind of shaking her head. She hadn't said anything, which was unusual for her. She was just kind of shaking her head in puzzlement. So I asked her what she was thinking, and she said, you know, she said, in my country, if you had the treatment, you'd use it. She said, how amazing it is to be in a country where the ethical questions are all about what to do with all the technology you have, not about why there isn't any treatment to offer at all. The two worlds of healthcare in my Notre Dame classroom are really just a hint of the multiple worlds of healthcare within which genetic technologies are now being developed and distributed. A report published by the World Health Organization in 2002, which was entitled Genomics and World Health, begins by acknowledging what is often called the 1090 gap, the reality that 90% of health research dollars are spent on the health problems of 10% of the world's population. According to the WHO, several features of genomics research reflect and potentially exacerbate this gap. And here I'm taking directly from the report, but I think it's important. Most genomics research was initially undertaken in the public sector of developed countries. But a recent survey reports that private company spending on genomics has overtaken and is now substantially higher than government and non-for-profit spending. The concentration of research funding in developed countries, as well as in the private sector, has implications for setting research priorities and for accessing the products of research. The private sector does not invest, should be no surprise, it does not invest in research aimed at diagnostics or therapeutics for diseases that are predominant in developing countries because the populations that are afflicted and most likely to need them do not have purchasing power. In order to ensure high returns on their investments, companies tend to focus their research and development efforts on products aimed at diseases and health problems that are most prevalent among the populations of the developed countries. In 1997, for example, it was estimated that low and medium income countries accounted for only 20% of the global pharmaceutical market, even though they made up over 80% of the world's population. Just to indicate the scale of this, the biotechnology industry has doubled in size in 10 years, generating 191,000 new direct jobs and 535,000 indirect jobs in 2001. Revenues for that year totaled more than 20 billion directly, 28 billion indirectly. I used to try to play off The Graduate. You know, do you remember in The Graduate where the man says it's plastics, young man, you know, I say biotechnology, but I get total like minus. Can't do that anymore. Just like you can't talk about, you know, landing on the moon and that's kind of like dating yourself. Even public research funding is driven in large part by market concerns through the increasingly common practice of public-private partnership. WHO argues that public research programs tend to be focused on diseases such as cancer and cardiovascular diseases that are priorities in developed countries whose economic interests drive global research priorities. For example, the report notes, it has been estimated that pneumonia, diarrhea, tuberculosis, and malaria, which together account for more than 20% of the disease burden of the world, receive less than 1% of the total public and private funds devoted to health research. Now there's some promising developments in this regard on the horizon. You're probably familiar with the UN fund to fight AIDS, TB, and malaria. There's also recently been a grassroots project called the Roll Back Malaria Partnership. But even there, I think it's important to note that even there, funding for malaria is simply a drop in the bucket. In the first round of funding for the UN fund to fight AIDS, TB, and malaria, there was a total of 616 million US appropriated. Of that amount, malaria programs got 22 million. So we're still talking about not very much. Malaria's funding tends, since malaria kills between 1 and 2 million people per year, we average between $40 and $80 of research spending per malaria death. According to the Department of Energy, and again, if we're looking at research priorities, in 2002, there were 600 clinical gene therapy trials involving 3,500 patients going on worldwide. As you can imagine, the vast majority take place in the US,